Thank you, Dr. Kshitij and Dr. Chetananjan for having me here. Pitfalls in radiological diagnosis of bone tumors sounded a tricky topic, and as Dr. Daftari says, tell me the solutions and not the problem. So we'll have a mix of pitfalls as well as its solutions to the best of my knowledge. The outline is first we'll look at the masqueraders, the tumor mimics, then we'll go ahead and see what's the role of multimodality imaging, and finally the diagnostic dilemma. Let's look at the first case. Someone complained that there were lack of images in the previous talk. I'm sure there are many in this. What is this? Is this a lesion? Is this a tumor? Or can we just let this go off? So this is something that's pseudocyst of greater tuberosity, which is commonly seen due to increased cancellous bone and does not need to be investigated further. Let's look at the next case. Is there anything on this radiograph? There seems to be a lucency over here. So what is it? Do we need to investigate further or sleep over it or follow up? So let's look at the MR image of the same patient. We went ahead and did an MR imaging. And there's this posterior femoral cortical lesion, which is classical of a cortical desmoid or distal femoral irregularity, also known as the tug lesion, and it is touch me not, do not touch me lesion. That's the third MR image. This is edema on the STIR images with iso-intense signal on non-fat sat. So this is a red marrow island, which is again normally seen in young patients as well as in those with red marrow reconversion. So what's the take home from these three cases? It's knowledge of the pseudo lesions and mimics which appear in typical locations and they do not be investigated further. Another example is the soleal line in tibia and the fibular cortical thickening, which we often see and need not be investigated further. Let's look at the third case, 58-year-old patient with forefoot pain. Can you find something? Yes, there is this periosteal reaction in the second metatarsal neck. Is this a stress fracture? Is there an underlying tumor? Or is there osteomyelitis beneath it? So let's look at MR and see what does it look like, and clearly shows the fracture line, which makes it a stress fracture. So MR is the gold standard, and we don't need X-rays. Is this what we want to take away from this? Let's clarify this doubt in the next case. So this is a 33-year-old patient with pain attributed to a trivial traumatic event. There is periosteal reaction, soft tissue edema, cortical thickening with some sclerosis. So what is this? Is this fracture, infection, or tumor? Can we answer this question only on this MR images? Maybe as a radiologist, I would say no. So let's look at the X-ray. And we see this typical cortical thickening in the fifth metatarsal neck, which is very classical of a Nora's lesion or a bizarre parosteal osteochondromatous proliferation. So MR may sound like a superior investigation, but X-ray has its own role. So are MR and radiograph sufficient? Let's answer this on this fifth case. This is a 23-year-old patient with severe pain in the ankle joint. And we just jump out of our chair and see there's this lesion in the fibula. It looks benign with a well-defined zone of transitions, narrow zone of transition. Looks like an osteofibrous dysplasia on this. So is this the cause of pain? What do we do next? Let's look at the MR images. And we see there's significant calcaneal marrow edema with a line. So there's a stress fracture in the calcaneum, which was not seen on the X-ray at the first look. So this could be the cause of pain. But what's the reason for marrow edema in tibia? This is the lesion in fibula. There's marrow edema in tibia. There's marrow edema in calcaneum. We don't see any stress fractures in tibia. So what is the reason for it? How do we proceed? Let's look at the CT images. So on CT, this is the calcaneal stress fracture. And what do we find in tibia over here? There's a discrete osteoid osteoma. So this patient has a calcaneal stress fracture. There is a tibial osteoid osteoma. And the radiograph showed that there is a fibular osteofibrous dysplasia. So it just emphasizes that no modality is sufficient in itself to make a diagnosis. Everything has its own pros and cons. No modality is superior, none of them is inferior. Every modality is unique, and it is the combination of these that help in arriving to a correct diagnosis. Let's look at the sixth case, 50-year-old patient with diffuse body pain. That's the pelvis radiograph. We see multiple lytic lesions scattered all over the bony pelvis. We also have a skull radiograph. Are these multiple lytic lesions multiple myeloma? Are these metastases? It's a common clinical question that we come across in our day-to-day practice. What do you think this is? And how do we go ahead with it? So we go and check the clinical input, as Dr. Daftari emphasized in the previous session, and the patient has an elevated parathyroid hormone levels in a routine blood test. So this is a classical case of hyperparathyroidism with brown tumors and pepper pot skull, and just helps us solve the case easily. Let's look at one more example. 63-year-old patient with mastectomy in 2012 for carcinoma breast found this solitary sclerotic lesion just day before yesterday. So what is this? Is this sclerotic metastasis? It has very low uptake on the PET CT. Is this just a bone island, or how do we go about it? Do we biopsy it? So again, clinical history, we went ahead and checked, does she have a prior imaging? And this is the prior CT scan of 2019. There was no lesion. So it makes our job much easier and tells us that this could very well be a skeletal metastasis from the carcinoma breast. So the third solution for this pitfall is clinical inputs, clinical radiology, and being a clinical radiologist and look at priors as well. Let's look at the last set of examples. This is a 21-year-old patient, this is a 33-year-old patient. Similar looking lesions in the calcaneum and this one's in the talus. This is T1 images, calcaneal lesion, and this is the talar lesion. Two separate patients with similar imaging morphology on MR. These are T2 weighted images. Are these tumors? Are these infections? What is it? So one of these, this one turned out to be a giant cell tumor, and this one turned out to be tubercular osteomyelitis. So the solution for the fourth one is, at times even we are helpless, and it's the histopathologist or the pathology correlation that helps in solving the dilemma. The take home from last 8 minutes or 7 minutes or so is, it's important to have a knowledge of normal appearances and variations so that we don't go ahead and investigate further. It's the multimodality approach. No investigation is superior. It has its own role and is indispensable in its own right. And clinical insight is invaluable. Thank you.